Hola, buenas noches, ¿cómo están? Soy el
Hello,
doctor
good
José
evening.
María Remes
I
Troche
am Dr. Jose
y
Maria
el día de hoy
Remes Troche.
damos inicio a nuestro año académico
Today we
2025
start our
de la Sociedad
2025
Mexicana de
academic year
Gastroenterología
of the
en
Mexican
este año de
Gastroenterological
celebración
Association.
de 90
This year
años
we are
de nuestra
celebrating
institución académica.
our 90th
Esta primera
anniversary.
actividad
This
educativa
first
es el
educational
webinar de
activity,
la sesión
which is the
del mes de
webinar
enero.
of
Es una
January's
sesión
monthly session,
especial en el sentido
will
de
be
que
a
hemos
very special
pensado
session
iniciar el
because
año con un
we have
tópico
decided to
altamente
start the year addressing a
relevante, de
topic that
actualidad
is
y
very,
controversial. Este
very
segundo punto
controversial,
es
a
el
hot topic,
diagnóstico y el
which is
tratamiento
the
de la
diagnosis and
sobrepoblación
treatment
bacteriana del
of
intestino delgado.
small intestine
Esperemos que
bacterial
a lo largo de
overgrowth.
todo este año,
We
sesiones como
hope
la que tenemos
that
hoy sean
throughout this
sumamente
year,
importantes para
we
mantenernos en un
can
alto
organize
nivel
sessions
de
similar to
satisfacción.
this one so that we can keep
Permita de
the
repente
high
ver
quality
tanto al
standards of our
paciente desde una
associations.
perspectiva
This
diferente
will allow us to see and
y
treat our patients
en
from a
ese
different
sentido,
perspective and
en
in a
esta
more
sesión muy
comprehensive way.
particular, tenemos
In
el
this
enorme
specific
placer
session,
de que nos
we have
acompañe
the great
el doctor
pleasure
Marc
of
Pimentel
having
y el
with
doctor
us
Ali Rezaie,
Doctors
que
Mark
son
Pimentel
autoridades
and
en
Ali
en este
Rezaie,
tema.
who are
Voy a ceder los micrófonos
authorities
a
on this
mi
topic.
coanfitriona, la
Allow me to
doctora
give the
Mercedes
floor to
Amieva
my
Balmori.
co-host, Dr.
La doctora
Mercedes
Mercedes
Amieva.
Amieva es la
Dr.
secretaria de
Amieva, as
Relaciones
you
con
may
esta
know, is
asociación
the
y a mí
Relations
tengo el
Secretary
honor
for the
de
association.
presentarla y de
It's
cederle el
my
micrófono
honor
para que nos
to
dé
introduce
un
her
avance
and
de
give her
nuestros
the floor
ponentes
so
y
that she
demos
can briefly
inicio
introduce
a
our
este
guest
webinar
speakers
del
so
mes de
that we
agosto.
can
Adelante,
start
Mercedes.
this
Muchas gracias.
January webinar. Thanks,
Buenas noches,
Mercedes. You have the
bienvenidos a
floor.
todos. Y como comenta el
Good
doctor
evening.
Remes,
Welcome,
empezaremos con el
everyone.
pie
As
derecho
Dr.
con los
Remes just said,
invitados
we are
del lujo.
starting with
Vamos
the
a tener
right
al
foot,
doctor
as we
Marc
say,
Pimentel
with the great
hablando sobre el
guest speakers.
diagnóstico
Dr.
del
Mark
SIBO.
Pimentel will speak
El doctor
about
Marc Pimentel es profesor en
diagnosis.
Cedars-Sinai
He's
y es
professor
director
at
del
Cedar
programa de Ciencia
Sinai.
y Tecnología
He
en
has
el
the
México
Science and
Asociado.
Technology
Él cuenta con muchas
program.
publicaciones, más de 180
He has
publicaciones
more
en
than
PubMed,
180
específicos sobre
publications
sobrecrecimiento
in
bacteriano,
PubMed,
tiene más de 30
particularly about
publicaciones.
SIBO. He
También
has
vamos a
more than
contar con la
30
presencia del
publications.
doctor Eli
Also with
Rezaie.
us is
Él
Dr. Ali
también
Rizai,
nos va a hablar sobre el
who will
tratamiento de SIBO.
speak about
Él es director médico
the
del
treatment
Servicio de
of SIBO.
Motilidad
He's the
Gastrointestinal del
medical head
CDCI
of the
y
GI
es director del
Motility
programa
Service
de
at Cedar
Extensión para
Sinai. He
Biotecnología
has the
asociado a nuestra
bioinformatics
Ciencia y
and
Tecnología
biotechnology
y también
program
cuenta con muchísimas
associated with
publicaciones
the
en este tema.
science and
Entonces tenemos
technology and has
a
many,
uno
many
de los expertos
publications on the topic.
a nivel
So
mundial
we have two
que nos van a
world
estar platicando
experts
sobre esto.
that
Así
are
que
going to
bienvenidos, es un
address
honor
this topic.
tenerlos y adelante.
Welcome. It's a pleasure to have you with us. Over to you, Dr. Pimentel.
Thank you very much for this opportunity. It's such a pleasure to be speaking with you today. And of course, Dr. Remes Troche, is always a pleasure to see you. Thank you again. Kicking off your 90th year, let's talk about SIBO and what's new in the diagnosis. When I talk about SIBO, it's very hard for me not to talk about IBS in the intertwined nature of irritable bowel syndrome. And I'm going to cover that as I go through this presentation. But, we talk about IBS as a symptom diagnosis based on Rome criteria. But now in 2024, here we are, and all we get are symptom drugs approved by the FDA. Why? Because IBS is characterized as a symptom diagnosis. We have to move away from that. We don't talk about Imodium in Crohn's guidelines. We never do that because Imodium treats diarrhea, but they have pathophysiology. So we have to move to pathophysiology. And I'm going to make the argument that SIBO may be a part of the pathophysiology of up to 60% of IBS. And we're going to go through this. But I want to start with pathophysiology of IBS from post-infection IBS. It would be very hard for people to argue that food poisoning doesn't cause IBS in 2024. In fact, I would say it would be ridiculous not to say that food poisoning doesn't cause IBS. This is the latest meta-analysis now with 49 outbreaks, 1 in 6.9 patients. So basically 1 in 7 people. If 7 people ate at a dinner and got Campylobacter, one person's going to end up with irritable bowel syndrome for an indefinite period of time. What's really important about this study is they were able to break it down by pathogen. I will caution you about parasites because they only had 2 studies in the meta-analysis on parasites, and that is the highest percentage going to IBS, but it's only 2 studies. The bulk were in the bacteria category. But look at Campylobacter, 20%. So 1 in 5 people who get Campylobacter now will help IBS. And we've actually modeled this using statistical models in the United States, and it is predicted that about 60% of IBS could come rationally from food poisoning. I'm not going to go through all the details of how we got to this point, but using food poisoning models that I've presented multiple times in conferences in Mexico, we've actually identified the toxin in food poisoning that through molecular mimicry is attacking the enteric nervous system and specifically vinculin in interstitial cells, leading to a slowing of the gastrointestinal tract. And this blood test now can diagnose post-infection IBS. And I want you to focus on not the specificity in the bottom, because the specificity is 90+%. I want you to focus on the sensitivity, 56%. That looks low, but remember, out of 100 people who meet Rome criteria, we think only about 60, it comes from gastroenteritis. So 56% is not far off. And if you look at IBS, the test, the new test for irritable bowel syndrome using these markers, it's the most accurate diagnostic test for IBS we've ever had, reaching medical certainty and post-test probability as high as 98%. Now, what we can do with this new model, these animal models, is we can discover what's happening. How does IBS develop from food poisoning? And in this study, we actually took rats and gave them a vaccine of CDTB. And then 3 weeks later, gave them a booster of CDTB toxin. And guess what? They developed IBS. They developed wet stool. And the higher the antibody, the worse the diarrhea stool was. So these antibodies are not a marker of IBS. We believe they are a cause of IBS because the higher the antibody, the higher the phenotype. But what we were then able to do in these rats is to show that their microbiome changes. They get overgrowth, and that's where I'm introducing bacterial overgrowth here. So a group of rats who got the toxin, the green dots, they didn't get any change in the microbiome. So they're the 6 people who went to the dinner, got Campylobacter, but now do not have IBS. But the ones who do develop problems fall into 2 microbiome categories in these rats. One is an overabundance of E. coli, the other is an overabundance of D-sulfovibrio, and we know those organisms as hydrogen producers and hydrogen sulfide producers. I now want to shift the gears to looking at the small intestinal microbiome. When we talk about SIBO, and you want to find out using culture, using sequencing of the small bowel, you have to do a lot of work, and we did a lot of work to validate the different techniques that are needed. And this is a very difficult challenge, but this is how not to do it. So this is a study that was published in a Nature Communications, a very high-level journal, but they didn't use the double lumen catheter, they used a single lumen catheter. They treated the aspirate like a urine culture. They added the blood agar to the McConkey agar. You can't do that because E. coli is growing on both, and they didn't treat the mucus in the aspirate. So it was a very, very poorly assessed study. And we know that this group didn't do it right because their own group, the Mayo method, this is Ken Jemmy and Lacey, 20% of samples collected at Mayo were contaminated because of the single lumen catheter. So you can't have a gold standard of culture if you're not doing it right and you're using a single lumen catheter. You need a double lumen catheter and you need to follow specific techniques, which isn't what's going on. So then publications become challenging. So, and then there are capsule technologies to look at bacterial overgrowth. This one came out in Nature. Now, I'll show you the pictures on the left. This is the capsules trying to diagnose overgrowth or how much bacteria. And it's all brown. Now, the capsules come out in the stool, you got to retrieve them. We've done aspirates for the Reimagine study for 5 years. Nothing in the small bowel is brown. It's all yellow-green, nothing is brown. So there's something that has to be addressed with this capsule. There's another capsule that was just published literally in November on using a capsule to be able to detect the quantity of bacteria and send it wirelessly to your phone. So it works in vitro. They haven't tested it in vivo. This is the in vitro study. The problem is the company is in bankruptcy. But what I will say, in the Reimagine study, using the proper techniques, culturing it the proper way, using a double lumen catheter, we see remarkable things in the small intestine. The small intestine microbiome, based on color, is extremely different from stool. And it's a very, very unique place. So with that starting point, I want to say, well, how do we get to bacterial overgrowth using these techniques and then moving on to breath testing and other techniques? But the problem is SIBO it's not your grandparents' SIBO anymore. It's not the old school Bill Roth 2, blind loop syndromes, malabsorption syndromes. These were patients who had dramatic, destructive foregut surgeries, and their bacterial levels are 10 to the 5, 10 to the 6, 10 to the 7th because of how badly damaged the structure of the gut is, no acid, etc. And so that's not the type of overgrowth we're talking about here. But the causes of overgrowth are many. So when I focus on IBS, it's because I think it's the most common cause. But anything that slows the gut down, adhesions, scleroderma, diabetes with neuropathy of the gut, mitochondrial diseases, HIV, older age, all of those things can lead to SIBO. So you have to be careful as to what the cause of SIBO is. But going back to SIBO and IBS, that being the most common cause, this is a meta-analysis from Australia. There's no argument. It shouldn't be an argument. SIBO is more common by breath test in IBS versus healthy controls right here. And 15 of these 25 studies in this were rated as high quality studies. And so this is well established. This is not our group. This is across the world, studies across the world. Culture studies say this exact same thing. There's more bacteria in the small bowel of IBS patients as compared to healthy. And this study established that rate of IBS-D and SIBO as 60%. But then taking it further, this is a breath test on the left. At 90 minutes, a rise of greater than 20 parts per million on lactulose. 84% specificity for SIBO by culture. So comparing breath test to culture, you get 84% specificity. Comparing it to sequencing, it fits because you get elevated gamma proteobacteria. And this is the most important thing in this validation of breath testing. The hydrogen is upregulated in the small bowel in patients who are positive. So the hydrogen is not coming from the colon. This is not a transit issue. It's upregulated in people with hydrogen positive. Here's the problem with breath testing. There's 3 gases: hydrogen, hydrogen sulfide, and methane. And it's the hydrogen sulfide that's linked to diarrhea now, and methane that's linked to constipation, and we'll go through that. But this is the first study in history where we do deep sequencing, shotgun sequencing of SIBO. Culture positive SIBO on the right, culture negative on the left. And so you see there's dramatic differences. But this is not your grandparents' SIBO. SIBO is not colon bacteria moving into the small bowel. That is not what SIBO is anymore, because now we can see what it actually is. It's literally 2 bacteria. It's Klebsiella pneumoniae and Escherichia coli, making up the bulk of all of SIBO. So think about this. You have 2 bacteria that invade the small intestine and wipe everything else out. Not just colon bacteria, 2 gram negatives. Not only that, we can get to the strain level and look at this. 1 strain correlates with every IBS symptom. 1 strain. This is important because what we show is that because you have E. coli and Kleb being so high in number in the small bowel, they are like Ferraris for degrading glucose. They can degrade glucose 63 times faster than a normal microbiome because they're there. So those patients who say I bloat after 5 minutes of eating, it's possible because these Ferraris, E. coli and Kleb, are there. And what they also do, seen in the Reimagine study, the destruction of a microbiome, even antibiotics, are not as destructive as when E. coli and Klebsiella are up on our deep sequencing of the aspirates. And the higher Kleb goes, it's even worse. The microbiome basically falls apart. So now we have 3 consensus statements on breath testing, and for the most part, they agree that about the criteria of SIBO, and they mostly agree that SIBO and IBS are interrelated. But there's a new breath test now in the United States that measures all 3 gases. And I want to go through this because this is really important because it defines 3 different microtypes: small intestinal bacterial overgrowth, intestinal methanogen overgrowth, and now the new one, intestinal sulfide overproduction. Now, using this 3-gas breath test, I'm going to skip this for time. We've done the first study in history where you take IBSD in a randomized double-blind placebo-controlled trial registered with the FDA, and an IBSD trial, the same kind of thing, randomized, registered with the FDA. And in both trials, we have breath tests with 3 gases in the beginning and the microbiome, and we know their symptoms. And what we see is that if you have DIBS, you never have methane. If you have CIBS, about 60% of C patients have methane, and that's what it looks like. D patients have hydrogen, and at 90 minutes, the majority of IBS-D, these patients were not selected for bacterial overgrowth. These are IBS-D patients, but the majority meet the criteria for 20 parts per million rise at 90 minutes. And they have hydrogen sulfide elevation as compared to the other groups. We're able now to figure out the exact bugs that are associated. So if you think breath testing is not validated, I just showed you it is. And I'm showing you here that not only is methane validated, it correlates exactly with the amount of methanogens in the gut. So the methane on the breath correlates with methanogen quantity in the gastrointestinal tract. So it is truly measuring what we think it's measuring. And so in IBS-D, we see hydrogen sulfide pathways in the metabolomics of the stool. In IBS-D, IBS-C, we see methane producing pathways elevated. And just like the rats, if you focus on the left side, the rats I told you after infection, humans get 2 microtypes, one driven by hydrogen, which is SIBO, and one driven by hydrogen sulfide to produce more diarrhea, more aggressive symptoms. And then, of course, on the methane side and constipation, we don't know why methane goes up. It's not food poisoning, but it goes up and then you get constipation. One step further of validating breath testing. This study, breath is taken, aspirates are taken, and we compare the breath result to the aspirate from the duodenum. The amount of methane on breath test is proportional to the number of methanogens in the small intestine. And the methanogen in the small intestine that's most important is Methanobrevibacter smithii, just like I've been saying. Methane causes constipation. It slows the gut down. This is a study from 2006. You put methane in the gut, you get 60% slowing of transit. But it doesn't slow by paralyzing. It slows by causing hypercontraction and stasis. It slows by stopping the gut. And this is a great meta-analysis by Sepide Merivar from our group. She did a meta-analysis of studies of methane and constipation, and methane is associated with constipation or more constipation and associated with less diarrhea in symptoms. This is a very important study from Stanford. At Stanford, they showed using capsule endoscopy or wireless capsule smart pill, they showed that transit is slower in people with methane. But we did the same thing with hydrogen sulfide. We measured hydrogen sulfide in the breath of patients, and we measured hydrogen sulfide producing bacteria in the small intestine in the duodenum. And the bug that came up in the small intestine that correlated with hydrogen sulfide is Proteus mirabilis and a couple of others. So we now know who's producing the gas we're seeing on the breath. And the more of these bugs there were, the higher the hydrogen sulfide in the breath of the patient was. So Now breath testing tells us we have one of three different types. We have SIBO, which we've always known, and now we know who they are. It's Escherichia coli and Klebsiella pneumoniae. We have intestinal methanogen overgrowth that causes constipation. We know the big actor here. It's Methanobrevibacter smithii. For intestinal sulfate overproduction, we now know the cast of characters. In the small bowel, it's Proteus plus a couple of others. In the colon, it's Desulfovibrio and Fusobacterium. And this has allowed us now to be able to develop new drugs. We have two new drugs, one going into phase 2B trials in about a month. The FDA documents have been submitted. And that one is for hydrogen sulfide and SIBO. And we have a drug that blocks methane, and that will be starting human trials, hopefully by the end of this year, because we know the cast of characters. I think this is an amazing study. I will present it briefly. This is the Cork, Ireland group, the #1 microbiome group on the planet. And what they showed is that there are really a small number of, so they took every single microbiome study ever done in IBS, pushed it together because every one of them is a little bit different, and said, who are the big problems? And the big problems are two, among others, E. coli and Fusobacterium, which is the hydrogen sulfide producer in IBS-D. The even more important thing is the right. This is the effect of rifaximin. Rifaximin works because, in part, it reduces E. coli and Fusobacterium, and it pushes the microbiome not down like an antibiotic, but pushes it closer to normal. And that's why rifaximin is so effective. It's getting rid of the SIBO bacteria and pushing the bacteria, the microbiome, back towards normal. I'm going to finish on this extremely important paper because this Indian consensus has the luxury of all the data we have, or most of the data I'm presenting today. The last guideline we did in the United States was in 2018, so it doesn't have all this amazing data to lean on. But the Indian consensus says, Statement 5, IBS and SIBO are related, grade A recommendation. Statement 6, methane and constipation are related. Level of evidence is 1, and it's a grade B recommendation. And that food poisoning and causes IBS, it's a cause of IBS, grade A recommendation. We are finally on a path where pathophysiology could be driving IBS, and we're understanding the consequent microbiome changes from food poisoning. So in conclusion of this presentation, SIBO is associated with IBS. The meta-analysis, you could cherry pick studies from there, but the meta-analysis, 15 high-quality studies out of 25, shows conclusively breath testing is important. The 3-gas breath test is the most validated breath test in history because it is validated against symptoms, and it's in IBS, and it's validated against the microbiome, that it is actually showing what's in the microbiome. And so now we have intestinal sulfide overproduction, and you're gonna see much more at DDW on this, and intestinal methanogen overgrowth. We have a 6,000 patient study that reveals a lot of new things about how these gases interact. And so there are 3 microtypes now based on sequencing and breath testing. And because of these, we can now develop the drugs we need to treat the causes of IBS. So I thank you for your time and attention.
Perfect. Thank you so much for inviting me. And congratulations on the 90th anniversary for Mexican Gastroenterology Associations. That's amazing. And hopefully I'm here and give a talk when it's 100. So what I'm going to talk about quickly is about the management of bacterial overgrowth and also intestinal methanogen overgrowth. And I'm going to amalgamate both. And I'm going to try to keep it very clinically relevant for you, especially because this is a common thing that we see in our clinical practice. So I break it down into 3 pillars, right? One is to see if there is any underlying cause of SIBO that we can modify, right? Whatever that can affect the motility of the small bowel or even the colon or both. it can potentially slow down the motility, and that leads to dysbiosis, right? So, for example, if you have a patient that is on large doses of narcotics, you'll try to see if the patient can come off of narcotics, although sometimes that's not possible. In that scenario, I've tried Pomoras, right? Mu receptor agonists, and to see if that helps the patient, and I have had good results with that, right? Somebody with inflammatory disease of the small bowel, now whether because of the Crohn's disease, EGID, or uncontrolled celiac, again, they have a big overlap with bacterial overgrowth. And now, if you treat the bacterial overgrowth without addressing that underlying inflammatory disorder, well, small bowel motility is affected. So SIBO is going to come back quickly. So addressing that underlying inflammatory issue is key. And similar to diabetes, somebody who has an A1C of 12 obviously is gonna, and the gut is affected, it's really hard to treat bacterial overgrowth unless we address the underlying cause of diabetes, and so on, right? For example, if patient has adhesions, can we address the adhesions? If patient has a diverticulum, is this something that we can address? So I constantly look for an underlying cause in my SIBO patients to see if I can take that away to decrease or even take away the chance of recurrence in these patients. The next comes down the induction of remission. An induction of remission is when we slam the bacteria and we decrease the abundance. Obviously, we can never make it zero, and that's not how antibiotics or any antimicrobial effects work. You just want to decrease the abundance so the body can take over and help your body, right? And another way that I'm going to go into more detail is elemental diet. And following that, you always need to adopt a maintenance of remission. Now, this can be with a diet. I'm going to go through what I do anecdotally with taking away very fermentable food as opposed to going very hardcore like low FODMAPs. I take a very lenient approach there. And meal spacing. And also sometimes I use migrating motor complex phase 3 modulating drugs, and also counsel the patient regarding the chance of recurrence. So that's essentially overviews how I manage these patients. So let's go to those points one by one. So induction of remission, let's talk about the most common thing that we use, antibiotics, right? So if you look at all antibiotics, the effective rate is about 51%, and that's one very important point there, because sometimes we in the past we used antibiotics as a diagnostic test. So it was like, okay, let's give this patient antibiotics. If patient doesn't get better, it's not SIBO. But that's not necessarily the right approach, because a lot of times you're not successful in eradicating SIBO. So that's where the points that Mark was making about making the right diagnosis first is very important rather than empiric therapy in these patients. There is another meta-analysis that for rifaximin specifically, the rate of eradication is about 59%. But even in that case, you can see that 40% of the times it's not successful, and you have to revise and change gear to manage these patients. Now, what antibiotics can be used? Rifaximin is available. Ciprofloxacin, there's data behind it. Neomycin, Septra or prim sulfamethoxazole or metronidazole. There are all good data behind them. I also anecdotally use doxycycline in my clinical practice. It's well tolerated, especially now that ciprofloxacin has some black box, at least in the US, about arthritis with it. I use that more when rifaximin is not available to me or rifaximin has failed. This is an interesting study that Mark and I did a while back, and this is data from Target 3 trial, where we assessed the IBS diarrhea response to rifaximin in multiple treatments. A subgroup of patients underwent lactulose breath testing at baseline, and then underwent treatment with rifaximin. So what was interesting was that in this study, placebo response was about 37%, right? But if the SIBO test was, the lactulose breath test was negative, then the response was 26%, so significantly less than the placebo response. However, if the lactulose breath test was positive, the response rate went up to 56%. And if the repeat lactulose breath test after rifaximin therapy was negative, the response rate was 76%. Those who follow IBS clinical trials and the very tough composite endpoint of FDA to reach, you know that 76% is almost unheard of to reach. But that just tells you that having a biomarker to direct our therapies is very important, and I think it's the future for treatment of IBS, because let's face it, not all IBS patients have SIBO, and the same thing, not all SIBO patients have IBS. So I think we shouldn't resort just to empiric therapy, especially in 2025, and not just with breath tests, other biomarkers we need to introduce to management of IBS. And this is one great example how biomarkers can help you gain almost a 30% increment in your response rate, which is pretty acceptable for a biomarker. Now, let's talk about intestinal methanogen overgrowth. Remember, when methane is produced, it requires hydrogen for production of methane. Hence, when you're treating them, you need to suppress the methane production, so you decrease the substrate for production of methane, and also you need to suppress the methane-producing archaea. The problem is that methane-producing archaea are rather tough to treat, and they are very resilient to antibiotics. Why? Because archaea have a completely different cell wall as compared to bacteria, and most of the antibiotics that we develop against bacteria works on the cell wall, and so it doesn't work on the archaea. There are a few exceptions. For example, neomycin or metronidazole do work on archaea. We do combination therapy. So not surprisingly, when you mix for example, rifaximin with neomycin, the response rate increases in management of these patients because you're suppressing the archaea, and also you do not allow them to produce methane, but suppressing hydrogen. So what if, the patient doesn't want to take antibiotics, or antibiotics are not getting any traction, or you're not, the patient recurs very quickly? What else is available? This is a study that Mark did almost 20 years ago, more than 20 years ago, where he looked back on the patients, retrospectively, on patients who received Vivonex Plus, which is an elemental diet, that they took it for 2 to 3 weeks, and see if this was helpful in management of SIBO and intestinal methanogen overgrowth. I have a slide after this to explain how elemental diet works, but in this scenario, we think that the reason why it works is that most of the food is getting absorbed at the beginning of the small bowel, and the rest of the gut doesn't see food, so it gets a relative reset in terms of gut microbiome. And good response was seen in this case, 67% symptom relief, which is a good a number to have. Also, you know that it's in the guideline, in fact, for treatment of Crohn's disease or eosinophilic esophagitis. We do have the option of elemental diet. So if you have a patient that has a concomitant bacterial overgrowth and Crohn's disease, or even celiac or eosinophilic enteritis or eosinophilic esophagitis, this is an intriguing option to use. But what's the problem? The big problem is palatability. Elemental diets are notorious to be very foul tasting, and that's because of the sulfur content of amino acids. Remember, these elemental diets are called elemental diets because they're back to their elements. Essentially, instead of polypeptides or proteins, they have free amino acids. And some of these amino acids are sulfur-based, so they are smell like rotten egg and they taste like rotten egg. So it's hard to make it palatable. And also they have broken down lipids, usually in the form of LCT or MCT oil, or and also they have carbohydrates in the form of monosaccharides or very short branch carbohydrates that break down easily, right? So because of this, they get absorbed at the beginning of the small bowel. That's why, for example, we like it in the setting of short gut syndrome or in the setting of fistula, because it decreases the fecal bulk, right? On top of it, it's allergen-free. It has zero protein, so it has no allergens. It has amino acids that helps with gut mucosal permeability. It has high levels of glutamine, and it in part helps with mucosal permeability, right? And also it helps with the macro and micronutrient deficiencies that some of our GI patients have, and also has optimal absorption efficiency, and it does not have any food additives that we know in the setting of IBS, food colorants, food additives, sugar alcohols. They all are harmful and causes symptoms in our patients, and especially in SIBO, sugar alcohols is a big trigger, right? But also they modulate the microbiome, which is a big plus for these elemental diets. Now, the good news is that now elemental diets are becoming palatable. So food engineering has moved forward immensely, especially with the advent of AI. And now with the combination of what ingredients to use, what ratio to use at what pH, now they're becoming palatable, right? So, and this is, you can see that, for example, this new palatable one is far more preferred by patients as compared to the older ones, both from taste, smell, consistency, aftertaste, appearance, and impression. So why is this important? Because the previous studies on elemental diet in Crohn's disease, they report 40 to 50% dropout because of the taste. So now if we have this, obviously we can make some breakthrough in treating patients with elemental diet short term. So this is a study that we did last year on 30 subjects with intestinal methanogen overgrowth and SIBO. 94% of them has had other therapies in the past, meaning that they have tried even elemental diet or antibiotics and they failed. So they were, the majority were treatment refractory. And what we did is that we screened them for 1 week, then we put them on exclusive elemental diet for 2 weeks, and then we followed them for another 2 weeks after they reintroduced their regular diet. And we checked the lactulose breath test at baseline and then right after elemental diet to see if we made any changes. And also we did daily methane breath test, and also they did daily questionnaires, and also took pictures of their stool, and based on AI, it was assigned whether what is the consistency of the stool, as so we are not dependent on the patient to tell us what is the consistency of the stool. So the achievement by palatability was actually was quite impressive, because 100% of the patients could do 2 weeks of exclusive elemental diet without a single dropout that we had in this trial, which was quite impressive. But another important point is that 73% of the patients normalized their breath test. So the solid line is the baseline methane levels at a 120-minute lactulose breath test, and the dashed line is the one after. And you can see that at all time points, methane has dropped. It's interesting for the hydrogen, as you can see, that the hydrogen is rising. The solid line is a baseline. And that you can see that at 90 minutes, it rises significantly over 40. And it's compatible with the general feature that we see in the small intestinal bacterial overgrowth. But then, interesting enough, after treatment, we see a rise in hydrogen, but it's much later. It becomes a colonic rise, right? It's not like antibiotics, right? That very broad spectrum systemic antibiotics that even affect the colonic bacteria. This leaves the colonic bacteria relatively intact, as we still see the peak at the end of the colonic fermentation. It's just that it switches a small bowel fermentation pattern into a colonic pattern. And very interestingly, on the daily methane levels, you can see that how quickly it drops the methane levels. And the ones who responded within 8 days, the methane level was below 2. And after reintroduction of food, you see a slight rise, but still it's below 4 part per million, meaning that it has lasting effect at least for 2 weeks. So how about the symptoms? One impressive thing that we saw is that at the beginning, only 38% of the bowel movements were complete, meaning that patients felt completely evacuated. This rose to essentially 68, 63, and eventually 69% that they felt completely evacuated. So there was a roughly 30% improvement in complete evacuation of bowel movements. And this was the number of bowel movements, interesting enough, in all of these patients. Some of these were constipation, some of them were mixed, some of them were diarrhea. So the average, in fact, didn't change much. If anything, during elemental diet decreased a little bit, and that's known because the fecal bulk decreases. And we looked at the consistency of the stool as well. Green is the proportion of Bristol stool scale of 3 to 5. And you can see that after they took elemental diet, just like any two-piece, the stool became looser. But then after they reintroduced the diet, they kept getting better and better, and the majority of them had normal bowel movements at the end of the study, which was again good results for us. Pain, discomfort, bloating, distension, diarrhea, belching, flatulence, improved. Fatigue. Interestingly, fatigue did not improve much by the end of the elemental diet, but then when we followed them 2 weeks later, they showed an improvement. And I don't have that data for you today, but this correlated with very interesting strains of bacteria. But I'm going to tell you, one of them is actually the Fusobacterium that Dr. Pimentel was just mentioning, which is the hydrogen sulfide producing bacteria, which is a fascinating concept if you think about it. And the same thing happened with brain fog. We only saw a tiny dip here, but then statistically significantly a dip in brain fog that we saw at the end. So, and also the same thing with urgency and also the improvement of constipation. So it appears that elemental diet is a good treatment for induction of remission. But one thing that we always have to tell the patient is that bacterial overgrowth has a high chance of recurrence. And this is a study from Loretano. It's now getting old, but I always reference it to patients that within 1 year, you have a 50% chance of recurrence. That sets the expectations with the patients that they're not disappointed that if symptoms come back, because that's part of the game when we're managing these recurrent and chronic diseases. All right. And what do I do for maintenance of remission to keep the disease away? If the patient is treatment naive, I try one treatment and see if they respond. Sometimes the disease goes away and doesn't come back. But if a patient that has been treated in the past and disease is recurring, then I adopt the maintenance of remission strategy. I start with meal spacing, very simple. I say that don't graze all throughout the day, don't munch, eat, and all throughout the day. Have structured meals, and have 5 hours between your meals. Why? Because we know the migrating motor complex waves, phase 3s, that are housekeeper waves, they only happen during fasting. If you keep eating, you would suppress them, and everybody would feel bloated if you continuously eat, right? So that's very important to have meal spacing between the meals during the day, and also overnight. And that's one of the reasons actually intermittent fasting in these patients does work, but the problem is that, well, that's not a long-term solution really. In terms of diet, I do take big fermentable foods out, sugar alcohols, cauliflower, broccolis, sprouts, and beans. I take them out, and I take dairy out. But I don't go really super hardcore like low FODMAPs to take a lot of options out because, a restrictive diets long term is not necessarily a good idea. So we call it at Cedars, we call it low fermentation eating. I'm happy to share the protocol that we use at Cedars for you, what we do to help keep the symptoms away. And as I said, migrating motor complexes are the key to keep the bacteria away. They can't constantly toilet the bacteria from the small bowel and dump it into the colon, right? So obviously, if we can accentuate them and help them, we can decrease the chance of recurrence. For example, if we use erythromycin at the dose of 50 to 100 milligram, we have 250 milligram tablets in the US. I cut it in quarters and they take 62.5 milligram at bedtime. And remember, these medications need to be taken at bedtime when you're fasting and the migrating motor complexes occur. At this dose, erythromycin tachyphylaxis does not happen. Remember, the half-life of erythromycin is about 2 hours. So it's out of your system in 8 to 10 hours. So if you use it once daily, or sometimes even twice daily, you don't get tachyphylaxis. But if when you use three times daily or QID, then that's the time you get a tachyphylaxis. Azithromycin 125 3 times a week. That's another option. There is some data on migrating motor complex with it. Another option is prucalopride. I think in Mexico, you have cisapride as well. I guess that's an option for you as well. The dose that I use for prucalopride is 0.5 milligram at bedtime. And sometimes if they see partial response, I go up. I go to 1 milligram at bedtime if they feel better. And again, I adjust the dose based on how patients feel, and some of them tolerate this really well. Remember, patients with SIBO may have even diarrhea, and I treat them that they feel better. I still put them sometimes, if they recur a lot, on a small dose of prucalopride. Small dose of prucalopride, even in somebody that baseline had diarrhea, is not going to cause significant amount of runny bowel movements. They tolerate it relatively well, although, the exceptions exist. So this kind of like summarizes what I do with based on the results that I get for breath testing for management of bacterial overgrowth. If I have hydrogen or hydrogen sulfide predominant bacterial overgrowth, I treat them usually with one antibiotic, whether amoxicillin, ciprofloxacin, doxycycline, rifaximin, bismuth. I sometimes use, especially if patient has significant diarrhea and hydrogen sulfide positive. That's one option that I use. Works well, cheap. And if patient has excessive amount of methane, then I consider combination therapy, for example, ciproflagyl, or I use rifaximin neomycin, or I use augmentin, so for 14 days. If clinical response is there, then I educate the patient about the chance of recurrence, and if needed, adopt a strategy for maintenance of remission. If not, then I consider elemental diet. I use sometimes elemental diet as first line if patients say that, no, you're not going to give me antibiotics, I want something else. So that's where I reach for elemental diet, right? So that's what I use. All throughout this, I always think about, is there something on the side? Can I modify the underlying cause to help the patients? Keep your keep an open mind about this. See if there is something that you're missing that is causing this recurrence of the symptoms that you can modify it, as I mentioned in the other slide. So just to summarize, this is how I manage the patient. Again, underlying, look for underlying causes possible to modify it, and then induction of remission, and then maintenance of remission. And with that, I'll stop the slides, and I'm happy to answer questions.
Pues sin duda hemos tenido un par de excelentes presentaciones.
We've heard undoubtedly a couple of excellent presentations.
Sin duda estamos empezando con el pie derecho.
So we are starting this year with the right foot. We have a few minutes to entertain questions from the audience. We have more than 688 people who are listening, who are connected. This is a very important number. We have people listening in the US even. My first question is addressed to Dr. Pimentel. I think that the way in which you have developed and shown that a screening test like the breath test, the biomarkers, the microbiome studies that show that there are at least 3 different subtypes, and this has an impact on treatment. As a result of this, we get the following question. In clinical practice, do you think that we should continue to trust the lactulose test? I mentioned this because this is the gold standard test. I know it's not perfect, but there are certain questions from clinicians, or they have doubts because some healthy subjects might have a false positive lactulose test. Should we trust lactulose as the first test? This may have implications in a country like Mexico where lactulose is not readily available. Mark, what can you tell us about the lactulose test?
What I can tell you is what I showed is that this is the 3-gas breath test, particularly because that was what was used. It's the most validated breath test in history. And never before, there's always been some degree of controversy about breath testing because we were not able to 20 years ago sequence the microbiome. We were not able to properly culture the microbiome. We were saying, oh, it's lactulose is demonstrating transit or and orocecal transit and those kind of controversies. But those don't exist anymore because we now show exactly that the breath test is exactly showing you not only who's there, but how much is there of the different microbiomes. And I think your point's important because I think what Ali is showing is that the breath test matters because you will treat less people if you have a positive breath test with antibiotics, if you're directing your therapy more. So sometimes the drug company thinks, whoa, less people, that's not good because I'd rather give rifaximin to everybody. I would rather give rifaximin to 100% of 60% than 20% of 100%. Because if we know who has SIBO, they're more likely to respond. But now it's getting even more dynamic. If you don't know they have methane, you don't give the right antibiotics. If you don't know they have hydrogen sulfide, you're not going to give rifaximin with pep. And that patient that I saw last week, who's now 1 year with no remission, she tried rifaximin 3 times. Then we did a breath test. She has hydrogen sulfide, rifaximin and Pepto-Bismol, 1 year, no symptoms. You're not going to know. So I think, we're going to have new drugs coming, which will also increase the enthusiasm around breath testing because, we have rifaximin plus, but there will be other drugs coming in. And I think that will be very exciting.
Muchas gracias. Y justo esta conclusión de tu presentación.
Thank you very much, Mark. And the conclusion of your presentation showing that with new technologies, we can distinguish 3 different subtypes. This leads to 3 different treatments. A question that results from the previous one is that we have many doctors from Latin America who are asking, in countries where we have limited availability of breath tests, do you think we can do a treatment trial with rifaximin in a patient with post-infectious IBS? At times, this is what we have to do because we don't have the test available and we see the response. But what do you think about this?
Well, to be honest with you, breath testing is not expensive. Rifaximin is expensive, but breath testing is not expensive, at least in the US, where the breath test is about $300 US. Rifaximin is $2,000. So you're saving money by knowing who to treat. And we've actually shown that doing a breath test can save up to $600 to $800 per patient. And could save the US healthcare system hundreds of millions of dollars because you're directing your treatment to those who need it, not to those where it won't work or may not work as likely to work. So I think it could save money. The other thing I just will point out that when it comes to methane, and Ali knows this well, or hydrogen sulfide, you don't need lactulose at all because you see it on breath 0. So you don't even need lactulose to prime it. So all you might need is a single breath to get that result if you have the instrument. So that could be even cheaper, possibly. You may not pick up SIBO, but you could pick up the other two gases, which means you have to change your therapy. So there are ways to make it less expensive for Mexico or for other countries where resources are handled differently. I'm from Canada, so socialized medicine in Canada has the same issue. They don't want to spend unnecessarily on tests.
Ok. Y ahora siguiendo con algunas de las preguntas de la audiencia.
Allow me to read questions from the audience. What is the treatment that we can currently use for methane overgrowth to reduce methanogens, specifically in patients with IBS? Let me add something to this question. What about the patients with excess sulfide? What would be the treatment for these patients too?
So for methane, I can answer that. So the strongest data is for rifaximin and neomycin, and I'm talking about 550 milligram of rifaximin 3 times daily, and neomycin 500 milligram twice daily for length of 14 days. So that's as a success. Now, anecdotally, in my clinical practice with intestinal methanogen overgrowth, I do use augmentin, which is amoxicillin and clavulanic acid, for 10 days. I've tried that too. Ciprofloxacin and metronidazole, I've used that as well. If obviously I don't have access to like rifaximin, or rifaximin is expensive for that patient. In terms of hydrogen sulfide, obviously data is accumulating. As Mark said, you can try rifaximin alone. Some patients do respond, but bismuth salicylate, the active ingredient of Pepto-Bismol, I'm not sure if it goes with that brand name in Mexico. It's very effective against hydrogen sulfide producing bacteria. So you can use it with rifaximin. I've done that. I have one patient with mild symptoms that actually responded really well to bismuth alone. So I've tried that as well. Those are, but definitely large trial is lacking, and that's coming as well. So that's promising.
Muy bien. Mark, hay una pregunta
Mark, there is a question
nos hace reflexionar un poco con
that makes us think about the metagenomic studies like Reimagine that represents sort of a pillar. This can guide us for treatment. Any differences in ethnicity, in the diet? I'm sure that the microbiome of Mexicans is different based on our diet. So we definitely need to conduct studies in Mexicans in our country. What you showed about Reimagine, what kind of population did they include and what kind of diet? Because as Ali said, it has been proven that the diet does have an impact.
Yeah. So this is a very important question that you're asking. And so the Reimagine study now, just to give you an understanding, we collect aspirates for sequencing, biopsies, blood, the demographics, the human genetics, saliva, stool, literally everything on these patients. And we have now the largest database of these aspirates in the world. We're at 1,100 patients. So while we don't have a resident Mexican population, we do have a Hispanic population here, and some of them are of Hispanic origin. And they are different because the food is different, and we see different ethnic groups even within our 1,000 patients, that the microbiome is slightly different from others. We also see diet changes the microbiome. Remember, these are patients that are coming in for endoscopy for whatever reason. We're not soliciting them because they have IBS. They're just coming in for endoscopy without colonoscopy. So we have a very diverse population of indications for endoscopy, plus a diverse population. So we are actually studying this. So this study on Hispanic versus non-Hispanic groups within our population, we already analyzed that data. There will be a paper coming on that. It is different, but not that much different. SIBO is universally similar between Hispanics, non-Hispanics, African Americans, and other groups. So SIBO seems to be very universal, with the one exception that in African American populations, there's a higher incidence or prevalence of methanogens. And that's a very interesting result.
Sí, yo quiero agregar aquí
Allow
un
me
poco
to
lo
add
que se ha
something,
hecho en México, el grupo de
telling you what has
México,
been done in Mexico, Max's group, and what we have done.
A la hora de la parte clínica, parece que no hay tanta diferencia en cuanto a respuesta.
Clinically, there appears to be no big difference in response to rifaximin. And I think that this should encourage us to continue to work on this, specifically with Mexican and Latin American patients. There's a question addressed to Ali. This is a question that has a very important clinical impact. It refers to probiotics. There is a large number of probiotics in the market. When you hear about this, and even more now, when we hear about the positive impact of the elemental diet on symptoms, the question is there evidence about the use of probiotics for maintenance of remission? Or should we carry out this kind of studies?
Yeah. No, there's a couple of small studies that obviously needs bigger studies, but overall, I have to admit, and you've seen the data on the probiotics and IBS. Overall, the data, even though the enthusiasm, I would say 20 years ago, was very high about probiotics, the big trials, when they are performed, there have been a little bit of a disappointment with the final results that we have seen with the probiotics. If anything, with studies like Placide trial, that we saw that patients after antibiotics that were put on probiotics, and these are the usual Bifidobacterium, lactobacillus, and we saw, if anything, patients on probiotics had more bloating and flatulence without any improvement in the rate of C. diff or antibiotic-induced diarrhea. And then I guess a little bit of a not complete, but a little bit of a nail in the coffin of the probiotics in the setting of irritable bowel syndrome, with the disappointment that we saw with fecal transplantation, right? Because if you think about it, what is the ultimate probiotic, right? Somebody's healthy microbiome, we just put it and plant it in somebody else to see if they get better. And what we have seen in IBS, that fecal transplantation is, in terms of response, is all over the place, right? So yes, there are some positive results that came out of Norway. Then the big study from Denmark that came out that, in fact, actually it was inferior to placebo. And the clinical trial in the US, FDA stopped in the middle because at the interim analysis, a placebo was superior to FMT. I'm not sure if there is any data on FMT in IBS, but that's again tells you it's about each individual is different. Something that is good for me is not necessarily good for you. So one single probiotic is not going to fix everybody. And depending on what is the native environment of your gut and what is the underlying motility of your gut, the bacteria that grows and is normal in me is not necessarily the same as you, and based on my diet. So I don't think we will have a perfect answer with probiotics in this scenario, and we need to think of it in different ways. And if anything, working more on the diet aspect rather than the probiotics. That's my take, at least.
Okay. Y tenemos otra pregunta acerca
We have received another question
el tratamiento con
about
en SIBO. Aquí en México hay
treatment
algunas personas que
for
lo utilizan,
SIBO.
sobre todo en pacientes que
In
tienen
Mexico, metronidazole
hidrógeno.
is used, particularly people who produce hydrogen.
Yeah, I'll take that too. Yeah, metronidazole is an option, and there is data to show that there is data that one from India, there is one study that was done in Lebanon, and yeah, it works. Yeah, and I use that as well. Obviously, nausea is one problem, and you can't drink with it is one problem. But I do use metronidazole if you know, the first line therapies don't work for me. Definitely an option. Absolutely. I don't know, Mark, do you use it still? Right.
Yeah, I mean, we did one study where we compared neomycin, metronidazole, augmentin, and all in a retrospective look, because metronidazole is in all the textbooks, the old Yamada textbook. But of all the antibiotics that we use for SIBO, I would say rifaximin is top. Ciproflagyl and augmentin are close. Neomycin is not that good, about 30% respond. Flagyl, about 25% respond, 75% do not. So yes, it can work, but you're going to get a very low efficacy, and I, you know, with a lot of side effects.
Bueno, creo que el tiempo se ha agotado. Creo que
I
podríamos
think we are sort of running out of time.
mucho más tiempo.
We could stay here and discuss this topic for hours, given the experts that we have with us this evening. However, it's time to end the session. But let's take advantage of this and let's invite Mark and Ali. We would like to invite them to the National Gastroenterological Week in Veracruz next November. We hope to have you as part of our academic program. It will be wonderful to have you attending the Mexican Gastroenterological Week. We would like to thank you very much for taking the time to participate in this session, stopping your academic activities in California. We send you a big hug, our greetings, and we hope to see you very soon in Mexico. Before I say goodbye, I would like to tell the membership about our next session.
Y que en punto, igual que en esta sesión, en febrero para el 26
It will take place on February 26th. We have an outstanding professor, Dr. Alan Bonder from Beth Israel from Boston, Massachusetts, speaking about new treatments for primary biliary cholangitis. We will send you a save the date and a reminder. Early in March, we will have a wonderful webinar besides the March monthly session to celebrate International Women's Day. We have prepared a program with the female leaders from Mexico and Latin America. They will address very interesting topics. With this, we close our academic session. Thanking you, all of you, for attending. Have a nice evening.